This little mini lecture will focus on the exemplar of asthma. Asthma is an exemplar of the gas exchange concept or oxygenation concept. It is a chronic inflammatory disease of the airways that causes hyperresponsiveness, mucosal edema, and mucus production. People who have asthma can have acute exacerbations, like when they're having an asthma attack. The inflammation of the airway manifests itself with coughing, chest tightness, wheezing, and dyspnea. It is largely reversible. Sometimes it can reverse itself by reverse spontaneously, or sometimes you need treatment. The strongest predisposing factor is allergy, but I do want you to realize that asthma can be life-threatening if the exacerbation is not treated. So if the airways become so constricted, it can go into an extent where it's extreme impaired gas exchange and respiratory failure. This is a diagram of the physiology or pathophysiology of asthma. Note that it has inflammation in the center, inflammation that leads to the symptoms, the cough, the chest tightness, the wheezing, the dyspnea. And your treatment modalities will be focused at decreasing that inflammation. Listed here are some risk factors for exacerbation of asthma. One of the first risk factors I have listed here are the allergens. Respiratory infection, if somebody has pneumonia or somebody has another type of infection of the respiratory system, this can make an asthma attack worse or their asthma exacerbate. My daughter has exercise-induced asthma, so she knows prior to exercise she needs to use her inhaler to open up her airway. Weather can cause exacerbations and exposure to different elements. Sulfur dioxide, food, medications, additives, all of these things increase a person's risk for having an asthma exacerbation. So what's the patient going to look like who has asthma? The big three are cough, dyspnea, and wheezing. Somebody that is having an exacerbation of an asthma or an asthma attack. Generalized wheezing. Sometimes you can have these people come in and you can hear them wheezing without even putting a stethoscope on them. And that is some severe wheezing. You know that those bronchioles are starting to close down, they're constricting, which leads to that chest tightness, dyspnea. They become diaphoretic, tachycardic. With that tachycardia, the body is trying to move blood around to get oxygen to the tissues. They have impaired gas exchange at that alveoli level. So if they can't get that oxygen to the tissues, they develop hypoxemia, and eventually they'll have central cyanosis, which is blueness around their mouth and their lips. So to diagnose an exacerbation of asthma, the healthcare providers are going to be doing a good history to determine whether there are episodes of airflow obstruction, a good physical exam, sputum and blood will be tested. Of course, we'll be checking the pulse oximetry and arterial blood gases to give us an indication whether there is hypoxemia present. A pulmonary function test is done to measure whether the patient is having decreased ability to exhale forcibly during times between exacerbations. These patients' pulmonary function should be normal, so that helps us diagnose an exacerbation if the forced volume is decreased, if they're unable to exhale forcibly. In your Hinkle textbook, figure 24/7 is a 6-step process to manage asthma. And there's a table right after that, 24.4, that goes into the different medications as well in 24.5. You'll be learning more about the medications in PathoPharm. I want you to know that patients have both quick relief medications and long-acting medications to treat their asthma. Obviously, if somebody is in an exacerbation, having an asthma attack, the inhaled short-acting beta agonists are the ones that, or the anticholinergics are the ones that we're going to want to use to open up that airway, to dilate those bronchioles. The corticosteroids are used to decrease inflammation, and then the long-acting medications that are on 24/4 are used. The people who have asthma use these medications even if they're not feeling ill, even if they're not sick. These are daily medications that they use to keep their asthma under control. So remember, asthma exacerbation can range from mild to severe. Again, I said earlier that it can be life-threatening. It can cause respiratory arrest. Status asthmaticus is the term used for a rapid onset of severe and persistent asthma that doesn't respond to the therapy that normally works to reverse it. Right? So what's happening is the patient is having severe bronchospasms and mucus plugging where they cannot breathe. They get asphyxiated. Okay, so they are gonna look like someone who is in extreme severe asthma exacerbation. They're gonna be very labored. They're going to have very prolonged exhalation. You may see some neck veins that are really engorged because the body is trying to compensate and get more oxygen in. There will be wheezing. What I want to make sure you know in this situation is that if you have a patient that comes in a status asthmaticus and is wheezing and extremely labored and the oxygen saturations are really low and they're showing all of those signs of impaired gas exchange, if that if that person stops wheezing, so you're auscultating, you hear wheezing, you go back in to listen and you hear no wheezing, that does not mean he's all better, okay? That probably means that his airway has closed down so much that he's about to completely stop breathing, okay? So if you have a patient in status asthmaticus and they are extremely labored and they are wheezing to beat the band, and then they all of a sudden don't have any wheezing, that's not a good sign. That's bad. You're going to want to assess your patient that has asthma, check the vital signs, get a pulse oximetry. You're going to want to assess their breathlessness or work of breathing, their ability to talk. Are they using accessory muscles to breathe? What's their mental status? What's their level of alertness or cognitive function? Are they coughing? How do their lungs sound? Are they wheezing? Pulmonary function studies are the most accurate way of assessing an acute or severe asthma exacerbation, but sometimes when somebody's having a severe enough exacerbation, they're unable to perform those tests. So an arterial blood gas will give us an idea of where they are with their gas exchange and their acid-base balance. Here are some nursing diagnoses for asthma. Ineffective airway clearance. This is because the airway is getting smaller and smaller because of the bronchospasms. There's also increased mucus production, increased pulmonary secretion, mucosal edema, and ineffective cough. Ineffective breathing pattern is related to the rate, whether it's too fast, too slow, the depth, how deep they're breathing, how effective their breathing is. And when it is ineffective, the body is not performing at that optimal gas exchange. They can also have anxiety, as you can imagine, it being difficult to breathe, change in their health status, they're just losing control. Fatigue and activity intolerance is another diagnosis. Their body is not they're not performing at optimal gas exchange, so they're not having the energy and the oxygen needed to do the activities that they need, and they'll be easily tired. And then lastly, knowledge deficit. They may not understand the treatment plan. There's a lot of that going on with asthma, and the asthma action plan that I'll show you in a little bit, and the different medications and when to take them. Here you will see our plan for our nursing process planning and what we want our patients to achieve. So we want improved airway patency for our asthmatics. We want maintenance of optimal breathing patterns, improved level of anxiety, increased activity tolerance, understanding of treatment protocol and preventative measures, and of course we want absence of complications. Knowledge is really the key to quality asthma care. We need to make sure that our patients know how to identify and avoid triggers that cause their attacks. They need to practice proper inhalation techniques. We have asthma action plans that the people with asthma need to be very knowledgeable on. In the action plan, there are certain steps and guidances based on what symptoms the patient is experiencing, what kind of medications they should take, monitoring the peak flow, using their peak flow meters, seeking medical advice or care if their condition worsens. Here's an example of teaching how to use a peak flow meter. So what this does, this peak flow meter measures the volume of airflow that the patient is able to do during forced expiration. So what they do is we teach the patients to take a deep breath, place their lips around the mouthpiece, and then exhale as hard and fast as you can. Okay, the volume that is measured in the action plan, there's actually color coded, meaning if they blow at a very good rate or a good volume, it's in the green section. If it's just mediocre, it's yellow. And if it is poor, really low peak flow measurement, it's going to be in red. So when the peak flow falls below that red zone, then patients should know that they have to take actions prescribed by their primary care provider in their action plan, which we're going to look at next. This is an example of that action plan I just mentioned. When I worked at Children's Healthcare of Atlanta on the respiratory floor, these action plans were printed out for every patient that was diagnosed with asthma. Everybody that went home received these action plans, so it could, and we instructed them to put it on the refrigerator, and if the child was age appropriate, to elicit their help with monitoring their symptoms. But it's a plan that will help them hopefully stay in that green zone, or the area where they're going to have optimal gas exchange, and not get to the red zone where they have such impaired gas exchange that it can be life-threatening. So these nursing interventions should be pretty familiar to you, because they're very close to interventions in all of our exemplars that we've looked at so far, and in our gas exchange concept. You're going to want to assess their vital signs, which includes monitoring the pulse oximetry. You want to assess their color changes. You want to make sure they're pink and oxygenated. You want to look for any kind of blue lips, blue nail beds. You want to assess how effective their cough is, whether they have secretions, and if they do, what does it look like? Does it smell? And how thick are the secretions? You want to assess their level of anxiety, assess for dyspnea, which is looking at the patient and seeing if they have flaring of nostrils, they're using accessory muscles, or you can see retractions, which indicate an increased work of breathing. Auscultate their lung sounds to see what kind of airflow you are hearing. Are you hearing wheezing? Monitor their peak expiratory flow rates and forced expiratory volume. That is done with the assistance of respiratory therapy. That's trying to help us get a better picture of how effective their breathing is. And then monitoring the arterial blood gases, the ABGs, and of course the patient teaching. These are all interventions for our exemplar of asthma. Now let's finish up that nursing process and look at expected outcomes. What do we expect our patient to achieve after we have intervened and provided patient teaching? So we want them to demonstrate improved airway patency. We want them to demonstrate optimal breathing patterns. We want our patients to conserve energy and increase their activities. We want our patients to verbalize a reduction in their anxiety. In addition, we want our patients to verbalize an increase in their knowledge about asthma and their management strategies. And lastly, we want to make sure that they have no other complications. Here is our nursing process for your asthma patient. You want to gather information about your patient's condition. You want to make sure you have nursing diagnoses and a plan in place to identify what type of nursing interventions you're going to perform. You're going to want to implement or perform those nursing interventions and then evaluate your patient to see if they have met their expected outcomes. Our interrelated concepts for our asthma exemplar are the same as for the gas exchange concept. With people that have asthma, they can have an acid-base imbalance based on how ineffective their breathing patterns are. They have anxiety because of the loss of control they may feel, or their inability to feel like they're taking deep breaths, inability to breathe well. The nutrition with our asthmatics are not as profound as with our COPD and our pneumonia patients, but good nutrition is always important for optimal gas exchange. The mobility talks about or is related because of the inactivity possibility and the fatigue that the asthmatics may feel when they're not being oxygenated appropriately. And then perfusion, again, is what takes the oxygen to the tissues and perfuses the rest of the body so that the body can perform in an optimal situation.